As Hugo mentioned, I'm here today to take kind of two of our talks from our lab at Reykjavik University. The first of which is predicting cardiovascular pathophysiology from a mid-thigh CT image. And the second is going over a paper that's still under review on soft tissue radiodensity, self-reported physical activity, and lower extremity function in AGES-Reykjavik. These two studies, more or less, are nice to talk about in tandem, as they both kind of are based on our fundamental field of study here on nonlinear trimodal regression analysis and sarcopenia. The first of these two studies, we recently published in Nature Scientific Reports at the beginning of this year. And the second one is under review in the same journal and hopefully should be published by the end of the year, but we'll see how things go. A bit of an outline on the presentation. I'll begin by going over kind of the basics of NTRA analysis, a bit more background on sarcopenia and our role with soft tissue radiodensity. I'll explain the method, how it was devised, kind of the mathematical underpinnings of it and what it means, and a little bit about the AGES-Reykjavik study and cohort, which is kind of the fundamental operative longitudinal based study that we work under. The first of these two studies, I'll go over the study paradigm and database structure, go over some of the results using multinomial logistic regression and machine learning models, and summarize some of our main findings from that work. And finally, in the last study I'll talk about is our mediation framework study. I'll walk through the mediation analysis and findings related to that study as well, and hopefully get out of here in time. So a little bit of background, right? So we're all here because we intimately care about muscle and its relationship with health, right? In an aging health, sarcopenia, a disease intimately tied with age, confers many changes in muscle size, contractility, architecture, fibrosis, aerobic capacity, myosteatosis, or the infiltration of adipose tissue into lean muscle, and changes in neuromuscular activation. For the purpose of our work in NTRA, we were interested in looking at CT-based assessment of changes in architecture, changes in size and contractility. And the field of CT-based radio imaging has a lot of potential in this regard. What we can do is say that in CT, we have a voxel or a pixel-based matrix of radiodensity values, which confer linear attenuation. The more dense the tissue, the higher the attenuation. These attenuation coefficients are expressed in units of Hounsfield unit, which is a linear transformation based off of a water and air-based phantom. So it's a standardizable procedure across CT imaging modalities. In soft tissue, we can isolate the range from -200 to +200 Hounsfield unit values to observe changes from adipose up through dense lean muscle. And in sarcopenia research, this is traditionally done to do two different things, either to segment lean tissue area or volume, or consider mean radiodensity from an entire voxel distribution or cross-sectional area. Now, there are a number of challenges with this. There's no consensus, of course, on a quantitative definition or a gold standard assessment methodology for sarcopenia. And in CT, these cross-sectional areas rely on one's own interpretation, largely on physiology. Where do muscle bellies begin and end? How do you control for partial volume effect? And mean radiodensity, the other metric, takes an average from all of these values. So an incredibly detailed and dense picture. We average out just a single mean value. And so we hypothesized that by looking at distributions in these radiodensity values, we could generate a method that provides more information in a subject-specific sense on skeletal muscle health. And so this brings us to the NTRA method. So when we look at these cross sections or volumetric elements in CT, we can plot a distribution of Hounsfield unit values or radiodensity values across, again, that range from -200 to +200 Hounsfield units. And what we end up finding is that there is a trimodal distribution in these radiodensity values, from adipose tissue being from -200 to around -10 Hounsfield units, lean muscle tissue being from +41 to +200 Hounsfield units, and the central peak that we call loose connective or water equivalent tissue that's centric near the 0 Hounsfield unit water equivalents, more or less from -9 to +40 Hounsfield units. And if we think about a mathematical representation of these three, understanding that in CT-based radiodensity, there is a probability density function that follows a Gaussian type of distribution. We see that we have 3 different Gaussian distributions that are summative, and adipose tissue and lean muscle tissue being skewed towards the central connective tissue peak. When we look at this mathematical representation, and this is represented by that summation formula that you see at the top, we have a number of different parameters that are characteristic to defining Gaussian distributions, and we can fit these parameters to each individual subject from their CT-based cross-section. And so what this ultimately enables us to do is assemble a matrix of 11 patient-specific, subject-specific parameters that describe kind of your fingerprint of skeletal muscle health. And what we found is that these parameters, amplitude, which is the end parameter, is more directly related to tissue quantity, relative tissue quantity, of course, from these 3 peaks, whereas tissue quality, of course, the other aspect of change in sarcopenia is indicated by lower width of these distributions, a sigma term, less skewed or less of this alpha term, and peaks located further from 0 Hounsfield unit values, more isolated lean muscle and more isolated adipose tissue. And so again, this came from the research question that rather than using just a single radiodensity value from these cross-sections, can we get in a more elaborate or holistic approach from using NTRA? And so how have we investigated these parameters, right? So we've worked primarily out of the AGES-Reykjavik study, which is a large population-based, longitudinally followed study based in Reykjavik, Iceland. We've looked at a host of comorbidities and health outcomes related to sarcopenia, such as LEF biometrics or lower extremity function biometrics, gait speed, timed up and go, isometric leg strength, continuous class comorbidities such as body mass index and solubilized cholesterol, and cardiovascular pathophysiology, namely cardiovascular disease or CVD, coronary heart disease, CHD, and chronic heart failure, or CHF. And we have a number of recent findings. What I'm going to highlight today in our two halves of this talk, I suppose, are our first publication in scientific reports on cardiovascular pathology prediction using machine learning modeling, and the second one that's under review, which is on this mediation analysis between physical activity and lower extremity function. So the first of these 2 studies, you can see the citation here. If you're curious, feel free to read any of these works. What we did was we took AGES parameters, these 11 different distribution parameters, and continuous class measurements. We asked the research question, can we use multinomial logistic regression as a classical statistical approach and compare it to more advanced classification modalities such as machine learning algorithms to predict cardiac pathophysiology from these patients? And so the study workflow is to use these CT-based cross-sections, run NTRA analysis to get these 11 parameters per subject, and then use 3 different comparative machine learning algorithms to classify individuals at risk for these conditions and assess whether or not there's any tissue-based relationship that's involved here as well. So the results, first starting with logistic regression models is kind of the classical tried and true approach to this. We see that using 11 NTRA parameters yields a high overall model significance to each of the 3 cardiac pathophysiologies. Individual significance from each parameter varies in specificity to condition, where CHD and CVD seem to follow analogous models relying on fat amplitude, connective tissue amplitude, location, and width. And contrastingly, the CHF outcome had basically every NTRA parameter significant, not just the fat amplitude and connective tissue parameters, with the exceptions of just connective tissue location and fat and muscle skewness. So this indicates that the prediction of CHD and CVD may only require 4 terms, with connective tissue being dominant, but this prediction of CHF requires more of these terms, 8 NTRA parameters with shared importance from all 3 different tissue types. Now, to unpack this a little bit more with machine learning prediction, we explored 3 different classification algorithms: random forest, ADA boosting, and gradient boosting tree. And these are assessed with a number of different kind of standard assessment metrics, such as accuracy, recall, precision, sensitivity, specificity, and OCROC, or area underneath the curve. And here, what we end up with is that we can do this prediction by pathophysiology. So again, looking at CHF, CVD, and CHD from these NTRA parameters. And we see that CHF obtains the best result within 95.9% predictive accuracy and 0.994 OCROC, which again, the OCROC here is maybe the most important of all of these values. It tells you the quality of binary prediction. And here, CVD and CHD, remember these seem to be paired, had strong results, but not as strong as CHF, with accuracies of 82.1 and 85% respectively. And all algorithms had the strongest scores with random forests, the random forest algorithm being used in the machine learning modality. If we look at this, we can further break it down into subgroups by tissue type and their ability to predict each of these outcomes. And we find again the same thing, that random forest models yielded the best predictive results. And interestingly, each of the three different tissue types had different or varying degrees to which they predicted these outcomes. So for example, the fat tissue was dominant in predicting CHD and CVD, whereas lean muscle was more reliant in the CHF model. And this altogether is kind of the first time we've used these parameters in a machine learning and classical statistics approach as a comparison towards the prediction of cardiovascular pathophysiology. And we found a bunch of different findings, right? We have both fat amplitude, connective tissue width are significantly and inversely related to all of these three outcome conditions. In other words, you want less fat and you want narrower, more specific connective tissue peaks. This suggests that an increase in fat tissue, the converse of this, and a wider connective tissue distribution, perhaps due to myosteatosis, are altogether predictive factors against cardiovascular pathophysiology. Machine learning models confirmed this in a more elaborate sense, but also allowed for the longitudinal assessment of CHF incidence, which was likewise robust. And you can see these results in our publication if you'd like, with an OCROC there of 0.993. And so in conclusion, this is a substantial step forward towards standardizable tools for predicting cardiovascular health in elderly individuals using changes in soft tissue radiodensity. So finally, I want to go over this second study here, which is a mediation analysis study on soft tissue radiodensity, again with NTRA analysis, as a mediator between self-reported physical activity and lower extremity function in the same database. So here, the idea is that from our previous works, we still wanted to unpack kind of a mechanistic question. Does physical activity lead to higher gait speed, timed up and go, leg strength, these LEF parameters, through changes in NTRA? In other words, through changes characteristic to each of the three different tissue types and their radiodensity. An example application of this is that physical activity is known to favorably alter various health outcomes in aging, such as Alzheimer's disease. But the mechanisms of this are not understood very well. And so if we can understand the role in physical activity in LEF through NTRA, we can perhaps hypothesize that NTRA fits in with almost any physical activity and health outcomes paradigm. So unpacking this in the mediation model, we start by first connecting our predictor, physical activity at AGES-1, to lower extremity function 5 years later. And we find that across all four LEF parameters, so this is fast gait speed, normal gait speed, isometric leg strength, and timed up and go, we have a significant relationship with physical activity 5 years prior to these measurements. That's the essential first step in mediation analysis, right? Does our predictor relate to our outcome? Second, we want to see, is our predictor also related to theorized mediators? So in other words, NTRA parameters. And here we correct for multiple comparison because we have 11 different models. And through Holm-Bonferroni correction, we find that 2 of our NTRA parameters are significant in the relationship with physical activity. And that is namely muscle amplitude and muscle location. So once we have these 2 parameters, these are the ones significantly related to our predictors. We then ask ourselves, are these related to our outcome of interest, right? Lower extremity function 5 years later. And so we find that yes, both muscle amplitude and muscle location, corrected for our covariates, age, sex, and BMI, are significant predictors of all 4 LEF outcomes as well. So finally—
5 minutes left.
5 minutes, thank you very much. So finally, once we've identified these potential mediators, we then ask, are these mediators partial or are they non-significant? So the way we do this is by first testing their addition into our prior models by adding muscle amplitude and location to physical activity towards the prediction of LEF in ages 2. And we find that across the board, we not only have significant beta coefficients for these predictions, but we also see an attenuation of our prior effects. So in other words, by adding muscle amplitude and location to our model, we've attenuated the effect of physical activity and LEF. So therefore, we can be sure that these two parameters capture some of that original variance and therefore are situated as mediators in this relationship. So finally, is this situation as mediators significant? This can be tested using bootstrapping. And so what we do is we use a bootstrapping procedure to randomly generate predictions based on indirect effects and direct effects. So in other words, indirect mediating effects from our mediators, muscle amplitude and location, and direct effects, which would be the remaining effects. And we find that across the board, if we look at this line of zero equivalence, we find significant indirect mediation effects from both of these parameters and significant direct effects from physical activity remaining. So in other words, there's still a significant remaining variance captured by physical activity that NTRA does not capture. Nevertheless, NM and muscle location are significant mediators in this relationship. So the summary of this is that in this particular study, which again is still under review, we found that increased physical activity confers better lower extremity function performance 5 years later. And so this again supports the notion that physical activity protects against deleterious outcomes in aging. But the variance captured by these models vary according to the LEF task. So in other words, it seems to be more related to something that's a little bit less, I guess, vulnerable to external variance like isometric leg strength, but weakest with something that might have more external variance in it, such as timed up and go. This also speaks to the identification of our mediators, muscle amplitude and muscle location. And this says that this is strong evidence, right? That physical activity promotes mobility in aging through the preservation of skeletal muscle quantity and quality. Again, the quantity term being amplitude and the quality term being location. So in relation to physical activity, we saw that increased physical activity incurred larger lean muscle distributions with mean radiodensities further from 0 Hounsfield unit values, in other words, higher quality muscle. And this relationship was also evidenced in lower extremity function, which says that improved lower extremity function, so again, gait speed, leg strength, and timed up and go, was related to both higher muscle amplitude and muscle location values. And so this is the first time that we've seen, again, these radiodensity terms observed in the capacity towards predicting lower extremity function and situated in this relationship between physical activity and functional parameters in aging. So I'd like to, with that, thank everybody, all of our colleagues at the Icelandic Heart Association, Reykjavik University, and of course, Ugo Craro and all the organizers of PaduaMuscleDays. If you guys have any questions for me, I'd be happy to field them just now. So, thank you.
Thank you, Kyle. Are there any questions from the audience?
Can I ask a quick question, Kyle? The CT radiographic density in terms of just the domain of bits that are encompassed out there. I mean, you have it published in Nature, so it would be audacious of me to try and find any chinks in your armor of argument. I was very curious that with a CT image, let's say of fats, is unable to differentiate between different types of fats, some of which have been well established to have a much better correlation with cardiovascular risks, such as, let's say, visceral fat versus subcutaneous, or IMCL versus EMCL, and so on. And the CT image, a simple one of the thigh that you showed, cannot possibly differentiate between, let's say, IMCL and EMCL. So I was really surprised at the very high specificities that you got in your classifications and so on. Are you able to, for example, differentiate, let's say, what are the effects of extra visceral fat versus subcutaneous fat in your very large population database?
Yeah, no, that is a wonderful question. And it's definitely something that from the beginning of this work has been on my mind. Of course, you bring up the relevant point that different types of fat are not the same, right? Especially in sarcopenia. So we have, in this case, a holistic based assessment of radiodensity, which of course cannot differentiate between different types of fat. Oh, I'm sorry.
No, abbiamo finito.
Oh.
Perché dico a Simona che... No, Marco,
Please go ahead.
Spostiamo
Yep.
domani.
Oh, no worries.
Sorry.
Oh, no. Yeah, thank you, Hugo. I think what I have thought of in terms of this project is the idea that based on the relative proximity of a pixel that contains mostly adipose tissue to other tissues that have higher density, we can see a buildup in kind of the central connective loose water equivalence peak. And that reflects myosteatosis, right? Or this idea of fatty infiltration to the intramuscular tissue belly in lean muscle. And as these kind of intramuscular adipose pixels accumulate, you kind of get this increased count in the central tissue regime, and you also get an increase in this kind of shouldering or kind of kurtosis effect in the fat and muscle peaks. And so those pixels, those values, I suppose, on those border ranges could be isolated in some way, I suppose, to identify intramuscular fat. But subcutaneous fat or adipose tissue that's not close to another tissue of higher density would be difficult to isolate. And so that's something that we're still kind of looking into, is whether or not we can mathematically separate different types of fat from these images. And if anyone has any suggestions or has had any success in this, that'd be wonderful to hear from you.